for patients.
So the room isn't ready.
It's very special.
And I guess another reason to do the auto cuff is if you check their Doppler and you get a mean, you're not sure if that mean is their systolic or their mean. You want to verify, because if it's actually their systolic, that might be super low, like lower than you want it to be.
So when you do Doppler, you don't know that you're definitely getting the systolic. It could be the mean.
Usually you're getting the mean, but if they're pulsatile, it might be the systolic. Might be. Yeah. So that's why it's good then to compare.
So I mean, you should be checking pulse to see if you can check a pulse on these patients, so that you would be able to know if you're getting the systolic or the mean, or hopefully that you're getting the mean.
Yeah.
Let's see. So with HeartMate 2, you're going to document the flow, the speed, the mode that it's in. So all of our patients will be in a fixed mode with a fixed rate, and it can fluctuate up and down by like 50 sometimes, just based on what the patient's doing. That you did your self-check, that there's a spare controller, and then on admission you want to put in the serial number. You don't have to do that every time. You don't.
Really?
No.
We put the serial number every time. And every time I'm like, why are we doing this every time? The serial number's not going to change. And it's a pain.
If you change the controller, then you want to document your new serial number.
Hallelujah. All right, no more serial numbers.
It doesn't say the protocol.
Like with every vital sign, we're documenting serial number, right?
I haven't done that in a while.
Well, that's good.
I don't think it's there.
It is. It's like the first thing, but it doesn't auto-populate or anything.
Oh, maybe other people weren't, so I just didn't notice it. Oh, I haven't had a heartbeat in a long time. Are they not on the hardware?
It should be on both.
I think it's only on maybe not. I don't know what I'm talking about.
Okay. Well, this is good news.
I mean, I never did it every time.
Okay.
So I didn't see the protocol that you have to do it every time.
Right.
I don't think if you're going to change it.
No. And we never change control. I mean, hardly ever. So once, I know. So what did you say? Once a day? Or once a shift?
On admission.
On admission.
Just the serial
on
number.
admission.
I mean, you check to make sure that their spare's there.
Yeah, you document that you have a spare controller. If you had to change it, then whoever changes the controller has to make sure that they document it's a new serial number. And it's a new controller.
Cool.
Capiche?
Mm-hmm.
And then with the hardware, you're going to document, again, the flow, the speed, mode, power, if the suction is on or off, spare controller, serial number, again, on admission only, or if you change the controller. And then you're just going to do the documentation whenever you do your vital signs. The protocol is kind of weird, so we're just saying vitals.
That's pretty much what we do. I mean, I think that's a good way to do it.
That's what we did in surgery too, so I think that makes sense. So reportable conditions for the providers, any emergency situations with the device where it's alarming and there's some sort of controller failure or mechanical failure of the pump. Consistent changes in any of the pump parameters. So in your nursing orders, you're going to see the flow should be between X and Y. If it falls outside of that range consistently, you want to make sure the provider is aware of that.
I don't think I've seen that before. Have you?
In the computer? In POE?
Like parameters for where our flow and everything should be. Let me check into that.
Just kidding.
I mean, that would be really nice.
So we should have orders in POE. What they're, right? Is that what you're talking about?
Yeah, that's what she's saying.
I mean, because it's just like their vital signs, and we have parameters.
Right. Okay.
Well, it's like your pacemaker settings.
Right.
Yeah.
You know what your settings are.
Okay.
Yeah, like we had a notify health officer if PI greater than blah or something like that. So.
All right, let me find out about that.
Yeah. I hope I didn't stir something.
No, it would be. I mean, that's good to catch that. I think we should have it. Yeah. Okay.
So persistent alarms. So something like the patient's low flow alarming a lot.
They told me
change in vital signs.
I wanted to wait till they had So her blood was drawn.
An increase in ecstasy or a change in their heart rhythm. Sudden changes in respiratory, neuro, GI, or GU status.
Do you want to ask if she's had
Sudden increase or decrease in their driveline drainage. Need for emergency or resuscitative measures. We talked about mechanical failure. Drainage or signs of infection from the exit site. And accidental decannulation is probably a good idea. Let Friday know if they stepped on their Lvad and it fell out or something.
Oh my.
Which would be really bad. So I'm going to talk about a couple of things that can go wrong with the pump. The first is pump thrombosis. So this is a patient who's probably going to present with an increased LDH and a decreasing platelet count. They're going to have that like dark cola-colored urine. They're going to get an increase in power, or they're just going to have spikes. So somebody who goes like up to 9 or 10, Mr. Nell came back with, well, I don't think we determined that he had pump thrombosis, but he had some power spikes at home. So these are patients that we want to make sure that they're anticoagulated and within their INR goal. A low flow. So the pumps are preload dependent, so it's not like before when they were active in their heart failure, we wanted to restrict their fluid. We're a little bit more liberal with their fluid intake because the pump depends on the preload in order to function. So these are patients who, if they're not having adequate intake or if they're MPO, we need to be repleting them in some way, and they can be really sensitive to diuresis. They're also afterload sensitive, so the pump can't pump against a lot of resistance. So these are patients that ideal map like 70 to 90, and if we're not afterload reducing, then they're not going to unload their ventricle effectively and move the blood forward. Anticoagulation will decrease the risk of pump thrombosis and clotting, so a lot of them are going home on Coumadin with aspirin. We don't use any of those like really
novel,
cool new. No, we don't use any of that. So if they've had thrombosis or they've had issues with their pump with clotting, their INR goals are usually a little bit higher, but usually it's like 2 to 3, 2.5 to 3.5-ish with these patients. So we'll monitor their INR here. Diet, teaching, and bleeding precautions are, and teaching with these patients are really important. I thought I had the alarms on here. Oh.
We can turn it off and go get them.
Yeah, I was going to say, I'm like, I had